Okay, so this is Jennifer Nelson. I'm reporting out on my project, which was based off how I could improve productivity in the emergency department through expanding two of my primary roles, which would be making my ED techs paramedics who are able to function under full scope of practice, as well as adding ultrasound guided IVs to the set of skills that nurses would be checked off on competencies. So for my audience members, I have Gina, who is my front office manager, and I have Paige, who is my compliance officer. So, so again, my project, improve productivity through expanded roles. So part of CMS guidelines is that we track quality metrics. And so based off of those quality metrics from CMS, for the emergency department, we have certain ones that we focus on almost on a daily basis. So these are aspirin on arrival for anybody who's discharged with a chest pain diagnosis, our door to EKG time, our door to discharge for our ED patients who are discharged from the ED. Another one that we measure is our door to doc time, so from the time the physician first starts that assessment. Our left without being seen, these are the patients that check in and then for whatever reason turn around and leave and never really get into the check-in process. Our Press Ganey standard overall score, this is an indicator of our patient satisfaction, and we'll go into a little bit more of that in a few minutes. And then we also measure our door to departure for patients that are admitted. So in our particular setting, this is patients that move over to our inpatient side. Our transfers are then actually in a different metric. And then our door to decision, so when our physician makes that decision to be admitted, we measure that time as well. Basically, for this next one, it's our bounce backs. It's these patients that come back, they were seen here, maybe they had belly pain, and then they turn around and they come back within 72 hours because our goal is to get it right the first time, and we don't want to have to, that can be a dissatisfier for patients if now they have 2 ED bills because we didn't get it right the first time. And then our last metric is our time to pain management for long bone fractures. So anybody that comes in with one of those fractures, are we getting them pain medications within a timely manner? So where did we start? So in 2017, Q1 data, this is what we call our red-green report. So the company that I work for is a joint venture partner with the Baylor Medical System. And so Baylor has basically said to us, hey, you are representing Baylor to the public, and so we expect your care to be top-notch. So what we do is we have all these metrics that I just reviewed, and then where we fell for January, February, and March of the first quarter of 2017. So what they have set for us is premium targets and threshold targets that would put us in the top 10 and top 5%. So you can see that we were really struggling with our door to doc times, and then we had some fallouts in some various other areas. And then when we look over here at our totals for the quarter, our threshold performance, we were still falling out in 2 different areas. We were only meeting that by about 80%, and then our premium targets were only being met at 10%, which was our aspirin, patients receiving aspirin, and we were not meeting any of the premium targets otherwise. So why do we track this? Basically, it comes down to CMS, Centers for Medicare and Medicaid Services. This was a focus for the Affordable Care Act, so this was made a high priority. That basically what they said is, we want you to focus on the quality of care you're giving, not the quantity of care. We don't want to be cranking patients in and out so quick that we're giving them poor quality of care. So all of those measures all of those metrics were ways for us to measure that we were giving good quality care. We as a facility then have to turn around and report those to CMS. And so this is collected and reported up. And this also has an impact on our reimbursement. So if we, have those 72-hour bounce backs, we might not get paid for that bounce back visit from an insurance company or CMS if it's a Medicare Medicaid patient. DNV. So everybody is familiar with Joint Commission. Joint Commission is an arm who is contracted by CMS to come in and make sure that facilities are meeting these metrics. DNV is also licensed to do this. So I think that they're kind of starting to give Joint Commission a run for their money. A lot of big systems are also switching over to DNV. So this is a company that is based out of Norway, and they have many programs. They started out in the maritime business. So basically, in 2008, they were approved to do this in conjunction with the Joint Commission to do these surveys for CMS. And so basically, this is a global quality assurance and risk management company, and they have an arm that's called the International Healthcare Accreditation Services. Let's see, so basically what they do is they fall in line with NIHO standards, and then they work with CMS to make sure that we're meeting all the metrics, and they take into different laws. They're in various countries, so they work with those various governments to make sure that they're meeting the requirements of those governments. So how do we make an impact on those numbers? How do we get those numbers to those premium targets? So start out with a broad focus. So using standing orders, making sure you have a good department flow, use of your electronic medical record for true time tracking. It's very easy in the old system of using paper charts to flub your times. But those also had to be manually extracted, so it was really hard to get an accurate measurement. So now, as part of the Affordable Care Act, you had to go to an electronic medical record. We now can get a better view of that. There's still some manipulation of numbers that can happen, but it's much more difficult to do, so we actually get a true picture of what we're doing. And then basically you start holding people accountable for those fallouts. And when you notice a fallout, making sure that you're having follow-up with those individuals, finding out what was the fallout, was it a process issue, was it a knowledge issue, and working to correct those as needed. And then you start to focus in on fine-tuning, so helping nurses to make sure that they're prioritizing their practice. So, recognizing that chest pain that just walked in the front door probably takes precedence over that discharge because you've only got 10 minutes to get that done, but your discharge still has to be a priority because you have that door to discharge time as well. So it's really identifying what is the priority and where you can kind of manipulate your workflow. And then that leads right into making sure as an individual you have an efficient workflow. This is a little bit harder to achieve. Basically, it comes down to identifying that person on the floor who gets it, who does it really, really well, and then having them mentor other nurses, especially nurses that are new to the emergency department, new to our particular setting where you don't have as many resources. We love the nurses that come from the big box hospitals, as we say, that come with, they work STEMIs on a daily basis, they work strokes and traumas on a daily basis, but they also had a wealth of resources available to them. So as I always tell people, busy is a perception. We can be just as busy as a big box hospital because you as the nurse are doing many more tasks than what you would in a big box hospital. So just making sure that we educate nurses on that. And then when we do have those fallouts, making sure we're drilling down to that individual case level and following up one-on-one, whether it's with a physician or a nurse or even a tech, and making sure that we correct whatever needs to be corrected. So after we did some broad spectrum tuning, where did our numbers go for Q2? A lot less red this time. We were still, again, struggling with our door to doc. Dr. Walker, who is our medical director, has made some great progress with this, as you will see. The numbers got a lot better, but we were still struggling a little bit. Didn't even meet that threshold performance for that. But what you can see is our threshold numbers basically went to only falling out for the door to doc time, and we crept up on those premiums. We started chipping away at those numbers as well. So, fine-tuning, what did I need to do to help us get to those premium targets? So I proposed some expanded roles for our nurses. One of the most obvious delays that nurses faced was obtaining blood specimens and IV access in patients who were considered difficult sticks. So again, in this setting, we have limited number of people who could try for an IV. There is no IV team to call. There is no NICU nurse to call for that baby. So how can we work to make this easier? Identified that this would have an impact on OP18, OP22, SO, ED1, and OP21. Basically, the solution that I proposed was incorporating EJIV skills and Sentinel IV skills into the approved RN task list. And we'll go into that more in just a minute. As far as our paramedics, currently they're employed as an ED tech. Paramedic or basic EMT is a requirement of the job, but they have limited practice since they're not working under the role in which they were educated to. So they're working under a very generic title with a very generic skill set, and not at their full capacity. Again, I identified the metrics that would be impacted if they were able to work under full scope of practice. So that was the solution I proposed, that we would develop a new corporate position for the ED paramedic in which ED techs with paramedic license would function under a full scope of practice. All right, so all of this, the hot button word in nursing is it evidence-based? So there are strengths and challenges of implementing evidence-based practice in the healthcare system. There are pros and cons to it. A lot of people will push a personal agenda and say, oh, it's evidence-based. I faced that in my last job when they wanted to make a no-fly zone from 6 p.m. to 8 p.m. for admissions coming out of the ED, that they could not travel to the floor during that time, which then of course resulted in a backup in the ED, because we can't say that we're not going to admit patients, and they were citing it as evidence-based practice, but yet never produced the articles. So it's being knowledgeable of the EBP process and making sure that what's being cited is actually quality literature. So what I did is I reviewed several studies that were done by several health systems, both magnet and non-magnet were included. Magnet being another hot button word. Magnet facilities are known for having quality evidence-based practice and kind of being the best of the best, and so they are usually a good resource for identifying best practices. Resources to implement evidence-based practices are key. You have to have the resource support to do it. If you are lacking the resources, to identify those best practices and things, then you're going to struggle to get things implemented. Magnet facilities often have access to more resources and nurses that were educated on how to identify evidence-based practice. So that was one, this particular study identified that magnet facilities did that really well. Another thing that this article identified was that younger, higher education levels and certified nurses often had a better understanding of what evidence-based practice was versus maybe your associate's degree RN who's been practicing for 30 years and who isn't certified. They don't see the value in it. So that was some very interesting findings out of that study. So evidence-based practice that I was able to identify for this project, paramedics in the emergency room. So I was able to review a study that was based out of Florida, and when a paramedic brings a patient into an emergency department, they have to pass off to an equal or higher level of care. So what they did is they used paramedics in their ER to receive their ambulance traffic. So while as a nurse I might be tied up in a room doing a different task, I can't necessarily go receive a report on that patient. They employed paramedics who could receive that report from the paramedic and then hand that patient off to a nurse, and they saw a drastic increase in their times. So basically, patients were offloaded within 5 minutes. That was their measure. Did patients get offloaded within 5 minutes? It went from only 29% to over 53%, which was really impressive. And then when they looked at that 30-minute time frame, went from 66% to 83%. And then within 60 minutes, I can't imagine an EMS crew waiting 60 minutes to hand off a patient, but this went from 87% to 100%. So it was really a great study to show that, just looking at this one little sliver of an impact, that paramedics could have a huge impact. Another study looked at the advanced practice paramedic, which evidently is a new role that's happening out on the East Coast. It's really having a great impact, where these advanced practice paramedics who meet the certain criteria are responding to the scene and deciding what is the best location for this patient. And this is having a huge impact on the geriatric population as well as the psychiatric population. They can do a quick assessment in the field and determine that, yes, this is a psychiatric emergency. This patient needs to go directly to a psychiatric facility. And in turn, they are completely bypassing the ER, of course, taking into account risk factors as their drugs involved and things like that, where they may need to go to an emergency room. But this had a huge cost, and it was a huge patient satisfier because they were getting to the right care that they needed and were avoiding costly ER visits. So for the registered nurse piece of it, I found several studies that basically supported the use of ultrasound-guided IVs. In both of these studies, there was very strict criteria in which a patient would receive an ultrasound-guided IV. One study showed 76% success rate on ultrasound-guided IVs versus 56% on palpated IVs for patients that were deemed difficult sticks, with a start time of 15.8 minutes versus 20.7 minutes, which was pretty impressive. Again, this other study, again, defined education program, and those patients had to have 2 failed traditional IV sticks, and they found that after that, when they used the ultrasound-guided IV, that they had twice the success rate as a palpated IV, and they found it to be 2.7 times faster. So definitely some impact from having that in your skill set. So what was the process for working to implement this? I did an initial meeting with the CNO and the medical director for the facility in the region, and approvals were obtained. They said, yep, go forward, do it. I had weekly updates with the CNO and the medical director, and then I did a search to find out if there were other programs in Texas that were using paramedics to full scope in their ER. And then I researched the state of Texas regulations for paramedics, and then there was a development of the job description, and then again, practice guidelines needed to be developed. So for the RN piece of it, met with the CNO and the ACNO to discuss a plan for this. Our initial idea of EJ access was declined, basically related to the risk associated with EJ IVs and being the volume in which we would use it, which would be pretty rare. It would be difficult to maintain competency, but we did feel that the ultrasound guided IV would be something that we could move forward with. Again, there was weekly updates done with the CNO on this. I then worked to identify some successful education programs in the area that had happened, and so I looked then to develop that education program and identified instructors, reviewed our equipment, make sure that it was something that could be used for ultrasound guided IV, make sure we had the right probes, and then a practice guideline and policy had to be developed for that. So where are we at now? So we are into our last quarter. We have 1 month of data so far, and you can see that we've made a pretty big impact on our metrics, meeting all of our threshold targets. Our premium targets, we are, in most cases, just barely not there. I mean, we're setting at 1% and the goal is less than 1%, 91 and the goal is 92. So, I mean, we're very, very close in some areas, and I feel as these programs get up and running more, we would definitely have an impact on those premium targets. So where is this project at currently? Paramedics, the proposed program has filed an HR for approval. Basically, we are working through the budgeted process. Obviously, a paramedic working under full scope is going to warrant a higher pay rate than somebody who's working as an ED tech, and this is at this point unclear if it's going to be approved for the budgeting process because they are actually having to cut. So it is unclear if this will be moving forward just because of budgetary reasons. EJ access initially was declined, but approval for the ultrasound program has been received. The classes have been developed. The first class has been completed, and there's 2 more classes that are scheduled. And there's my references. So that's the program.
Awesome.
Good job. Thank you.